David, you can share your PowerPoint so we can.
You want me to go ahead and share?
Yeah, please. Yeah, go ahead.
Okay.
Yeah, we see the first slide. Thank you. So good morning and welcome to Pediatric Grand Rounds. The CME code, the correct CME code is in the chat box. Sorry, I entered a wrong one earlier, but this should work because this did work for me this morning. The first thing I did was enter this number and it worked for me. So it's my great pleasure to introduce this morning's Grand Round speaker, Dr. David Turner, who is the Vice President for Competency-Based Medical Education at the American Board of Pediatrics. He's also an Adjunct Professor in the Department of Pediatrics and Division of Critical Care at Duke Children's Hospital. Dr. Turner attended medical school and completed internship, residency, and year as a chief resident in pediatrics at Baylor College of Medicine and Texas Children's Hospital in Houston. So he was our neighbor for almost 8 years, not too far from San Antonio. He then completed his fellowship in pediatric critical care at Boston Children's Hospital. Over the course of his career, Dr. Turner has published over 150 peer-reviewed articles and book chapters and presented at a wide range of national and international venues. He held a number of local, regional, and national educational leadership roles prior to transitioning into his current role at the American Board of Pediatrics in September of 2020. In his role, he committed to helping lead a thoughtful transition to competency-based approach to learning and assessment across education continuum in pediatrics. Dr. Turner, thank you very much for accepting our invitation, and the floor is yours.
Thank you. Thank you for that really nice introduction, and thanks for the invitation. I mentioned earlier, sorry I can't be there in person. As was noted, I lived in Texas for a number of years, and San Antonio is one of our favorite places to visit. So thank you for having me virtually anyway today. So I'm going to spend the next 50 minutes or so talking about competency-based medical education and assessment. And over the course of the next few minutes, oh, by the way, I have no disclosures other than I'm fully employed by the American Board of Pediatrics. Over the next little bit, I'm going to spend a little bit of time talking about the ABP, who we are and what we do. That's probably particularly relevant for the trainees on the call who may have less exposure to the American Board of Pediatrics. And then the bulk of the time, we're going to spend talking about the principles of competency-based medical education, and particularly entrustable professional activity. So there's a lot of alphabet soup when you're talking about medical education and assessment, and I'm going to work on some definitions and some framing for those that may have less exposure to some of these concepts, and then talk about what that means for the future as it relates to training in pediatrics and pediatric subspecialties and certification from the perspective of the board. So what is the American Board of Pediatrics? Who are we? So we are at our core an assessment organization that's responsible for certification of pediatricians. And this is our mission. So our mission is really about certifying pediatricians who meet standards of excellence and are committed to continuous learning and improvement. And as we go through the next little bit of time and we talk about competency-based education and assessment, hopefully you will see how that aligns very clearly with our mission. And our mission is designed to help us advance our vision, which is really about advancing the health of children. So as we talk about education, assessment, certification, all the things that we do as an organization, this is the frame that we use in the work that we do every day. And the primary mechanism by which we as an organization are doing this is through assessments. So the board provides a number of different assessments, both in general pediatrics and across 15 core subspecialties. And we do over 50 assessments annually for the trainees in the room. The in-trainee exams are created by the same people, a group of peers who create the certification exams, which are taken at the conclusion of training. Our MOC proctored exams are taken much less often than they used to be because we've transitioned to a longitudinal platform. So for the faculty on the call, hopefully most of you are a part of our MOCA Peds program, which you get questions quarterly. And that's been a really popular program as we've continued to evolve how we approach the assessment of knowledge in the continuing certification space. And then once you're certified, For the practicing pediatricians and pediatric subspecialists in the room, this is probably familiar to you, but there are 4 parts of certification that are listed on the screen here, and we're responsible for setting and maintaining those standards and then partnering with pediatricians to make sure these are achieved as a part of the lifelong learning process with an eye towards helping us achieve the mission that I mentioned earlier. And so, how are we different than some of the other organizations that you're probably familiar with? So, we regularly get confused with the Academy, so the American Academy of Pediatrics. I often get asked about my role at the AAP, then I have to provide a little bit of clarification between the two organizations. But the AAP is a close partner of ours that we work very closely with, but they are involved primarily in advocating at the governmental level, developing guidelines and practice pathways, and they're a big part of the educational process for both trainees and for pediatricians, and are very clear partners of ours. And then, certainly in the competency-based education space, the ACGME is another partner organization. And for the program directors in the room, all of you are quite familiar with the ACGME and their role, and our role as a certifying organizations. As we certify individuals coming out of your programs, they have to come from accredited training programs, and we partner closely with the ACGME in all of this work. And so, related to that, sort of what is CBME and how does it fit in? And so now we're going to transition in the next several minutes. We're going to just talk about some of the principles and the concepts around CBME and how it applies to the future. So at its core, competency-based education is patient-focused and learner-centered. So CBME really is often described as beginning with the end in mind, right? So thinking about what are the needs of patients, what are we trying to accomplish as pediatricians or as pediatric trainees, what are the things that our patients need from us, and then working backwards to decide, okay, what are the knowledge, skills, attitudes, and things that are needed in order to accomplish those patient-focused goals. And so when you think about an educational program in a competency-based framework, really front and center is the ultimate outcome and sort of what the patients need. And you should always be coming back to that as you think about curriculum, assessment, individualized learning. And one of the benefits of that approach is as an individual, as you think about what you're able to do well and where your opportunities are, you can really identify strengths and opportunities for growth, and then individualize curricula so that you can ultimately achieve those patient goals. And so that's where the learner-centered piece of this comes in that there's a fair amount of individualization that should be a part of every competency-based education program. And CBME generally is described as having 5 core components. And I'm not going to go into these in a lot of detail, but I'm just going to cover them at a fairly high level. So I touched a little bit on number 1 on the previous slide. So this idea of an outcomes framework, right? So what is the expectation of the pediatricians and what are the outcomes that we're going to try to achieve? We as a specialty have defined that using EPAs, and EPAs might be a new term to many people on the call. I'm going to define that in just another minute. And those are integrated with competencies, milestones that you may be familiar with as a part of your current approach to assessment in your training programs. And then the middle part of the core components of CBME are really the work that happens at the local level in programs, right? So developing a program that allows for a learner to build on competencies over time and develop them in a sequential way so that both learning and teaching are designed to help each individual reach their highest potential. Because at the end of the day, as we have training programs in pediatrics and pediatric subspecialties, what we're really trying to do is let everyone reach their highest potential and achieve these activities that our patients need. And then finally, there's this concept of programmatic assessment. So that's basically a fancy way to say use multiple sources of data for decision making around advancement to decide if someone is ready or not for the activities that we've defined. And then as you're thinking about the assessment piece of this, there's always this reversion back to the first bullet on this slide, which is really, are we ready to achieve the outcomes that we're trying to achieve? So there's a very outcome-focused approach to both education and assessment. And none of this is new, right? We've been talking about competency-based medical education for really decades now. In graduate medical education, so in our residency and fellowship programs, CBME really began in earnest a couple of decades ago now when we integrated the competencies and the milestones into graduate medical education. So this likely is familiar to many of you. This is one of the pediatric subcompetencies around patient management, and you can see the milestone levels that are listed on the slide. This is the approach that most training programs in the United States really, regardless of specialty, but particularly in pediatrics, are using as their frame, right? And many learners and faculty are familiar with this progression. And this is how, generally speaking, we have assessed primarily for a number of years now. And one of the questions that I get asked, right, is if we have competencies and milestones, why do we need anything else? And one of the reasons for that is because competencies focus on tasks of individuals. So usually there are a list of things like taking a history or doing a physical. The one I just showed on the screen was this concept of patient management. But each of those are isolated tasks, and the idea of how to integrate those into the bundle of care delivery isn't necessarily captured when you're assessing the milestones separately. And assessing milestones without a clinical context can be quite difficult. And we certainly hear that from faculty and from learners as they're trying to figure out what are the things that I need to focus on to develop as an individual. And that's where EPAs come into the picture. So EPAs take the competencies that are currently scattered on the slide, and they bring them together into an activity that a patient needs. So I've referred to it a couple of times now. So this concept of the EPAs. So what is an EPA? In EduSpeak, an EPA is an entrustable professional activity. We've been working on rebranding these for a couple of years now as everyday pediatrician activities. That resonates better with people, and I think really does capture the spirit of what we're talking about when we talk about EPAs. And I'm going to show some examples in just a minute. But what EPAs are is they describe activities that patients need for optimal care. And then when taken as a whole, the EPAs can really define what it means to practice in a specialty. And importantly, they really are important not only for assessment, but also for thinking about curriculum. So if you think back to the beginning when I was talking about the patient-focused, learner-centered approach to CBME, if you define how to or what it means to practice in your specialty using the EPAs, you can then use those to drive not only your approach to assessment, but also how you build your curriculum. And it's also important, EPAs are not really a new concept or a new idea, and they're certainly not just another assessment tool. They really represent our work as a specialty to define what it means to practice in pediatrics. And we did that work a number of years ago to develop the framework. And I think now we're just in earnest really getting to the point where we're realizing we need to be integrating these principles better into our training programs and into our approach to lifelong learning as a specialty. And so if you step away from medicine for a second to sort of provide a non-medical example of an EPA, I'm going to use the example of learning to drive a car. So for anyone who has had teenagers or has had the experience of being involved in a child learning to drive a car, there are lots of things you have to learn. Can they control the steering wheel? Do they understand the rules of the road? Can they use the gas pedal? Can they use the turn signals? But the first time you ever get in the passenger seat as a parent, what you really want to know is, can they safely drive the car, right? And so in this context, the EPA or the activity that's needed to be done is safely driving the car. And then the competencies and milestones are all the component parts that are needed in order to do that. And what we usually do currently in assessment in medical education is we assess the left side of the slide, right? We do a really good job of thinking about the competencies and the milestones and what the individual behaviors are. But we sometimes don't ask the question, can all of those things be put together in a specific clinical context? And so what CBME really does is it flips the script, right? So it puts the EPA as the first priority to say, okay, can the person do this thing, whatever the thing happens to be? And then if the answer is yes, the component parts really become less important, right? Because if you can really provide the care to a newborn that a newborn needs, then you can integrate all the different elements like your medical knowledge, patient care, communication, professionalism, and the specific details of that become less important. But if the answer is no, you're not quite ready to care for a well newborn without supervision, then you can dive into those specific competencies and say, okay, what do I need to work on in order to be ready to do this as a pediatrician? And so switching back to medicine, right, all of these components are a key part of a comprehensive competency framework. And depending on whether you're looking at a situation with sort of a wide angle lens or in a very granular way, that's what this slide ideally represents, right? So if you think about the activity, so caring for a well newborn is an example of one of our EPAs. In order to do that well, there are a number of competencies that you have to integrate: medical knowledge, professionalism, communication, and then within each of these competencies, there are specific subcompetencies. So, for example, one of the communication subcompetencies is around patient and family-centered communication, which is a critical piece of caring for a well newborn. And then you can say, for an individual, what level are they in their communication? So maybe they're at the point where they can demonstrate respect and attempt to establish rapport, but they haven't really progressed along the developmental trajectory towards expertise yet. And then you can use that as a learning opportunity in this area with the ultimate goal of achieving the EPA, right? And so that the activity on the right side of the screen, right, the component parts, in and of themselves are important, but they're really mostly important as they relate to being able to do something that patients need, right? Which in this case would be caring for the little newborn. And if you look at our EPAs, the next couple of slides sort of break the EPAs down into sort of their anatomical parts. This is just an example of the consultation EPA. So EPA that applies to both pediatrics and to the subspecialties is the ability to provide consultation to others that are caring for children. And you can see EPAs are generally assessed using a supervision scale. So one example of a scale is listed here, with the first level being observation, right? So most trainees are starting above that level right off the bat, and there's some supervision that is required. And then you progress all the way to being able to do an activity without supervision. And the goal is, as you're progressing through training, you move along this developmental trajectory, and then you build your skills so that ultimately you can provide care and do these activities without supervision. And so within the activity, there's a description, and I'm not going to go through all of these in detail, but you can see as you read through the description of this activity, it integrates a number of competencies like we were talking about earlier, right? So the first one is really around communication. The second one is around information gathering and patient care. And you can see there are a lot of different component parts. So thinking back to the driving the car slide, right? This is the left side of the slide, right? That's outlined here in more detail. But all of these are only important in that they contribute to your ability to provide a consult, which is the EPA as an example in this case. And then when we developed the framework, we took these activities and each of their functions and we exploded them out into more detailed curricular components. And so this is where you can really think about, as you build a curriculum for a program, or as you as an individual think about your own learning plan and what you need to work on. These really read like learning objectives, right? So things that you can do within a given category that then contributes to your ability to do this larger thing, which in the example being provided is a consultation. And so we've developed the framework of EPAs now um, for general pediatrics and for all of our subspecialties that we are primarily responsible for as a board. And there are 17 EPAs for Gen Peds. Of note, these were all developed now almost 10 years ago. So they're due for an update. So we currently are in the process of reviewing the general pediatrics EPAs, and there are going to be some revisions that come out later this year that allow us to sort of streamline and consolidate, and then also just update them in 2024 language, since they were now written, like I said, close to a decade ago. And the Gen Peds EPAs, just to give you a snapshot of what they are, these are the abbreviated titles of each of them, are listed here. And as you think about, for those general pediatricians in the room, as you think about your own practice, hopefully as you go through this list, these are things that resonate with you as the activities that are important for you as a general pediatrician. And for the trainees in the room, hopefully these are the things that you are spending time doing every day as you're developing into becoming a pediatrician. And you'll see some of them are fairly specific, like, for example, Care for the Well Newborn, number 3, is a specific activity in a specific context, and some are much more broad. So EPA 4 is really about the management of common acute diagnoses in multiple settings. EPA 9 is about behavioral mental health, the management of children with those issues in a variety of settings. And so those are much more broad. And you can envision a world where there are lots of sub-activities underneath all of these that have to be assessed and thought about as you think about your development as a pediatrician in each of these areas. And then in terms of lifelong learning, for those that are in practice, there are some pediatricians that practice exclusively in the newborn nursery, as an example. Their area of focus will be primarily around a smaller subset of these EPAs as they think about sort of who they are and how they practice for the long term. And the only EPA that's been revised in recent history is EPA number 14, which is focused on population health and quality improvement, or at least it was originally. So we revised this EPA a couple of years ago because we recognized that addressing inequities and racism were inadequately addressed in the original framework. And so we decided, after much discussion, to integrate these concepts into the quality improvement and population health EPA, because we wanted to make sure that the concepts of addressing inequity, providing anti-racist care was connected to some action, with that action being quality improvement. And so thinking about how you can use quality improvement principles to improve your practice and address the inequities that we know exist in the care of patients is an important priority that we built into the framework. And as we revise the EPAs, as I mentioned earlier, we'll be integrating language around making sure that inequities are addressed really as a part of all of the activities, because that should really be part and parcel of all that we do. And in a perfect world, you shouldn't need a specific activity to call this out, because it's a part of everything that we do. And hopefully we'll get to a point where that will be the case for all of us in practice, and particularly for the children who need it. And so in thinking about that list of EPAs that I showed just a few minutes ago, hopefully, as you read through the list, there weren't any topics that you're like, oh, well, here's something that I do every day that really wasn't represented. Because we've heard fairly consistently in surveys and feedback that we gather on the EPAs that they do a pretty good job of defining the practice of pediatric broadly. And so the EPAs really represent what our patients and families expect and need from us as pediatricians. And then if you think about what we do, we, the board, as a certifying organization, we assess medical knowledge. And the medical knowledge assessment is a small portion of what it means to be a pediatrician. And if you think about the darker blue part of this diagram, that's the part that programs are responsible for assessing, right? So that's a decision that programs have to make along the way, readiness to practice for all of these activities. And then there's a knowledge assessment that we conduct to supplement that decision as we get into the process of certification. And thinking about how that process happens is really the heart of the evolution of CBME that we're talking about today. And just to give you a concrete example of what that looks like, this is EPA number 2, which is about providing recommended health screening, and the functions are listed here. And there's a very clear correlation between the first function of this EPA and our content outline, which is the multiple choice assessment that we do for initial certification, the application of knowledge and understanding of screening tools. And there's a clear sort of one-to-one relationship between the function of this EPA and the medical knowledge assessment that is conducted as a part of it. But the other 2 functions, right, these are about how you engage with families, how you communicate those decisions and the implications of results of screening tests. Those are things that are very difficult to assess by way of a multiple choice assessment. And that's where assessment at the level of the program really becomes critically important, right? Because these are the skills that are important to be assessed by programs that are ultimately attested to the board as we make certification decisions and as people progress and transition into practice. And that's really where this blending of certification, which is what we do as a board, and training programs really come together. And CBME falls squarely in the middle, right? There are pieces of this that are ours to own as a certification organization. There are pieces of it that are clearly falls in the purview of training programs, but there's a significant area of overlap as we think about how we assess, how we address readiness to practice as one progresses through training and then ultimately transitions to practice and moves into a pattern of lifelong learning. CBME is a framework to address that, and that's where there's a lot of overlap between particularly the work of training programs and us as an organization as we're moving people along to becoming certified. And so one question that I regularly get asked is, um, isn't what we're doing now fine, right? Why would we need to continue to evolve towards a more competency-based approach to education and assessment? And so the next couple of slides, I'm going to share some data from some studies that we've done over the course of the last couple of years that demonstrate some of the current gaps that we're trying to address as we think about advancing towards a more competency-based approach to education and assessment. So one area is that we have found that the attestations that are made by program directors are often based on very limited information. So for the trainees in the room, if you think about how often you get an assessment and how often those assessments go to your competency committees for decisions to be made, they're often overall, over the course of a 3-year training program, a pretty small number of assessments that are collected by competency committees. And this has been shown across multiple specialties, pediatrics included. So CCCs, when they come together to meet, are really making decisions on fairly limited information. And what we found through some qualitative work that we published a couple of years ago is that the most common approach to decision making in residency training is this default pathway, where unless there is a specific concern or a red flag identified, people are progressing along as they should. So it's sort of like being on a conveyor belt, right? Like you're on a conveyor belt, everyone is moving forward, and unless somebody stops the line to say, "Oh, there's a problem here," everyone is moving forward. So there is not as much intentionality in decision making around readiness to progress and readiness to do new things like supervise an intern or progress to a more senior rotation, that intentionality is missing in that decision making. And one of the things that we hope to achieve as we advance our competency-based work is a more robust body of information for programs for decision making, which also translates into more information and more feedback for learners as they develop, so that you can really create a situation where everyone is getting the attention that they need to develop to their fullest potential, as opposed to only identifying when there is a significant problem or a challenge along the way. So there's this idea of a focus on growth for everyone as they're developing as pediatricians. And the other piece of data that's important is that we have found both in general pediatrics and in the subspecialties that if you use the EPA framework for assessment, so if you ask the question, are people ready to do these activities at the conclusion of training? Yes or no, and what does that look like? There's significant variability. And so the biggest area opportunity for growth for us as a specialty is around behavioral mental health care. And so this is data that was published now about 4 years ago. And it includes about 25 residency programs and several thousand residents who are part of this study. And if you look at competency committee assessment of readiness to do the behavioral mental health EPA at the conclusion of training, only about half of residents were ready based on their program's assessment. So clearly there's an individual issue here, right? Like each individual is not ready to provide this care when they complete training, but this is a system problem that we need to wrestle with. And so we have created some partnerships with the program director community and building curriculum and thinking about how to address this problem at the national level. But this is an example of how if you use the EPAs as a frame for your assessment, it can can identify a systematic problem that we need to address as a community. So the behavioral mental health issue is real, and I think as programs modify their curricula in response to the next round of ACGME program requirements, which has a behavioral mental health component, thinking about addressing this issue with an eye towards keeping the end in mind is going to be an important priority. And if you take the entire EPA framework, right, so all 17 of the general pediatrics EPAs that I showed just a few minutes ago, less than 80% of residents were ready for unsupervised practice for those EPAs at the conclusion of training for 6 of the 17 general pediatrics EPAs. So there were lots and lots of places in some of our very core activities that there was ongoing need for some amount of supervision at the conclusion of training. And it's this variability, right, and helping people prepare themselves to do these activities at the conclusion of training as they're transitioning into practice that we're trying to address as we think about how to advance our competency-based framework. And in the subspecialties, the data are quite similar. So we're about to publish this paper, which shows that depending on the subspecialty and depending on the activity, up to 15% of graduating fellows aren't ready for unsupervised practice for many of the activities that we've defined. And not surprisingly, we're about to publish a study related to this because there's a lot of discussion right now around the workforce and the subspecialty duration of training. If you use the EPA framework for assessment, it is quite clear that many trainees are not fully prepared at the conclusion of 3 years, and they're certainly not ready at the end of 2 years if you use the current approach to fellow education. Now, could duration be different if there were a different approach to education and assessment? I think the answer to that question is probably, but at least in the current training paradigm, there are a lot of issues around preparedness that we need to wrestle with as a community, both in general pediatrics and in the subs. And it's important to remember these aren't just sort of an arbitrary set of activities that may or may not be important, right? These are activities that were defined in partnership with the community, both in pediatrics and in the subspecialties, as essential for practice, right? These are seen as activities that our patients need from us as we care for children in a variety of contexts, and there are lots and lots of opportunities to close these gaps as we think about the future. And just looking at one EPA in a more granular way, like this is the data from the study that we're about to publish. And so to orient you to the slide, the y-axis are the percentage of learners in a given category, and the x-axis represents the 5 different levels of supervision. So if you think back to the supervision scale that I showed earlier, the left side is observation only, the right side is unsupervised practice, and then there are different levels of supervision all along the middle. And so this represents about 1,500 graduating fellows across all of our subspecialties over the last 4 years. And this is only at graduation, right? So these are the graduation level data. So in a perfect world, everybody should be in the level 5 category, right? Because you would hope every fellow completing a subspecialty training program is ready to provide a consult without supervision. So the good news is about 2/3 of the trainees who are graduating fall into that category and are ready for unsupervised practice. But this other third requires some degree of supervision at the time of graduation. Now, the level 4s, for those of you that may have been involved in this study in the subspecialty world, this has been a topic of much conversation because the level 4 supervision scale is ready for unsupervised practice, except in the most complex of cases. And many subspecialty program directors see that as normal behavior for someone who's transitioning from training into practice, in that, when you're an early subspecialist or even when you're a seasoned subspecialist like me, you often will find a colleague and talk through a complicated patient, right? And that's normal behavior for subspecialists. And there are probably a large number of people in the level 4 category that are truthfully fine. However, there likely are people in that group that really do still need a GME supervisor for the complex patients, right? And those are the ones we really need to think about and think about how we can advance their education so that they're prepared for unsupervised practice at the conclusion of training. But there's no question, if you look further to the left, right, the 67 people that are level 3 or level 2 require entirely too much supervision to be graduating. And so those are the people that we really want to move to the right, right? And that's one of the, like I mentioned earlier, the gaps we're trying trying to close as we think about a robust approach to competency-based education and assessment as a broader community with an eye towards preparing people to do the things that we've defined as essential for practice using the EPA framework. And so how do we do this from a practical point of view? One of the ways is including the EPAs as a part of assessment early and often, right? Because what that does is it allows for addressing both issues at the individual level. So if an individual isn't equipped to do one thing or another because of some specific circumstance, and it allows us to address curricular issues at the program level. So if you think about the behavioral mental health example I provided earlier, clearly in many programs across the country, that's a curricular issue as opposed to an individual learner issue, because the exposure just isn't there for trainees to be prepared in the way that they need to be prepared. But the key part of this slide, which isn't really highlighted, right, is the idea of doing this early. Because if you think about the non-clinical example from earlier, the learning to drive the car, right, if you focus only on the left side of the slide, right, and the individual competencies, and you don't ask about driving the car until the very end, you may find, oh, wow, like this person is really not ready. But if you figure out early, can this person drive the car and why not? Then you can really develop their learning plan so that they can successfully achieve the ultimate goal of driving the car or caring for the well newborn or whichever of the clinical activities we're talking about here. And the other place the EPAs really have an important role is in curriculum. So most of this conversation today has been around assessment. And when we talk about entrustable professional activities, and certainly when we talk about it through the lens of a certification organization, we almost exclusively are talking about assessment. But EPAs have a key role in curriculum. And this is just an example of a couple of places that we've partnered with the program director community and APPD, so that's the Association of Pediatric Program Directors, to develop national curricula focused on important issues. So the two on the screen here around behavioral mental health and about addressing racism. There are a number of other ways you can use the EPA framework to guide curricular development, which is really a key piece of the educational process. And then your assessment aligns with your education in a way that's meaningful and a way that helps you achieve the goals that you're trying to accomplish either as a program or as an individual. And so thinking about what that means from a practical point of view, so EPAs can really simplify and I would argue improve our approach to assessment at the front lines in thinking about what faculty are asked of learners. So my guess is many of you have seen assessment forms or questions that ask questions similar to the ones that are on the screen now, right? These milestone-based questions that say, what level is this person for developing and carrying out a management plan? And as a faculty, there's sometimes challenges in answering that question because it depends on the circumstances, right? Because if you are an outpatient pediatrician and you're seeing a child with acute otitis media, a resident's ability to develop and carry out that management plan may be one answer. But if you are in the inpatient setting as a hospitalist and you have an acutely ill child with bronchiolitis, the answer may be different, right? So the context is really important. And so shifting towards an activity-based approach to assessment using EPAs to say, oh, how much supervision does this training need to provide a consult? Or how much supervision do they need to manage a child with moderate respiratory distress in the emergency room? These are decisions that faculty are making every day. So every day when you work with a resident and you see a patient in clinic and you decide the resident can do this without me going in the room with them, or I need to be in there the whole time, or they can just sign them out at the very end of the day. These types of entrustment decisions around activities are being made every day, and just translating that into information that's valuable for learners, right? So that there's a conversation around feedback and for competency committees for decision making. That's what we're trying to accomplish in a very sort of concrete and practical way as we think about assessing differently for the future, because the ultimate goal really is a meaningful approach to assessment to determine readiness for practice. And I've touched on sort of most of these points along the way, but this idea that assessment needs to line up with curriculum, right? So that the ultimate goal, we're keeping the end in mind throughout all the things that we do in the learning process. And it's also important to remember that someone being ready for unsupervised practice doesn't mean they're an expert. No one is an expert when they finish residency training. and there is a lot of learning that follows completion of residency training. But there's a level at which everyone should achieve so that they no longer need a GME supervisor and they're ready to do this care on their own. And that's the question that we have to answer. And a big component of that, which I really haven't touched on much over the course of the day, is this idea of knowing limits and seeking help, right? So if someone knows their limits and they're going to ask questions when they need to ask questions, that's someone that more times than not is ready to progress and is ready to provide care for a patient without supervision. And that's a really critical skill for all of us to both develop and maintain as we think about becoming pediatricians. So as you think about at the local level, how might we implement some of these principles that I've talked about that sometimes are a little bit ethereal and sometimes can be a little overwhelming is, what does a learning environment look like in your current structure, right? And where do you want it to go? Like, how do faculty and trainees interact? And what's the focus of the interaction, right? Many times interactions with faculty and trainees are quite transactional. And thinking about how we can really focus on the learning process and how we can make the learning environment conducive to that is a key element of implementation of CBME. And related to that is sort of what's the mindset, right? So the mindset, most of us, right, who get to where we are in our training or practice have been high performers for many years. And we've been graded and we've gotten this like A to E scale for many, many years. And everybody wants to get an A on every assessment that they get, right? But once you're in residency training, it's really not about getting a grade, right? It's really about, are you ready to do the things that patients need? And what can we as a global community in a training program help you achieve those goals, right? And so this idea of growth and continued development and you have to be assessed, right? But being assessed for learning, right? So that you can say, okay, I'm going to give you feedback on this interaction and here's what you can do next time to improve. So that the idea is that we are assessing for growth and for learning so that people can reach their full potential, as opposed to saying like, oh, like, your performance today was an A or a B or a C, because that's much less valuable than really helping people think about how they progress in training. And then what are the structures you can put in place to really help people achieve their maximum potential, right? And thinking about how you can individualize curriculum development over time in a way that helps each person achieve the goals that they need to achieve and ultimately be ready to provide the care that patients need. And so in the last couple of slides, where are we going with all of this as it relates to certification? So we use the EPAs now as we develop our assessments. So the content outline, which is the blueprint for the certification exam and for MOCA PEDS, starts with the EPA framework. So we bring a group of pediatricians together, we share the EPAs with them, and we say, these are the activities we've defined for practice. Do you agree with these? Yes, no. And then they carve out the medical knowledge components of those that are multiple choice testable, right? So if you're developing as an individual or your program curriculum is designed to address the EPAs in a comprehensive way, you are addressing the things that we will be assessing as it relates to certification. So creating this connection between training, certification, and lifelong learning really is one of the things that you can do with the EPAs and the CBME framework. And then we have put a flag in the ground in 2028 to say we are going to be using the EPAs as a part of the certification decision-making process by that time. And the concept there is that what we want is for programs to be to a point by then that they can say, yes, my trainees are ready to do all of these activities, and here's how we got them there. And that's really the spirit of what we're trying to do as we think about this process. And so what can you do today? What are the easy things? One is just review the activities, right? Spend a little bit of time thinking about the EPAs, how they relate to what you do, either as a trainee or as a faculty member, and how they might apply to your program, right? And so there are likely places they can be integrated in rotation goals and objectives and orientation materials for the new folks that have just joined in your program, and then thinking about how to build them into assessment forms and really create an approach to assessment that's focused on readiness to achieve these activities by the conclusion of training. And then for the program directors on the call, we have a pilot program that we're started now a little over a year ago, that if you want to implement EPAs broadly in your program and set it up so that you can get OMOC Part 4 credit for yourself and for your faculty, just let me know and we can talk about the specifics of that. And if you're really interested in being a leader, whether you're a trainee or a faculty member, you can click the QR and become a CBME champion. So the CBME champions are our new volunteer program And our goal is to have representation from each training program across the United States as someone who we can partner with to think about implementation of CBME at the local level and how we can really move this work forward as we partner with the community at large to advance our approach to competency-based medical education and assessment. And I believe that's my last slide. This is one of my favorite quotes, right? A lot of this is quite overwhelming. And I vary back and forth between this quote and the quote that is perfect is the enemy of progress, right? And so I think making a small step, taking a little bit of progress is not that difficult. And then after a period of time, after you've seen some of the steps that you've taken, you realize you've gone a really long way. And there's some examples of this across the community as we think about how we have advanced our competency-based work over the last couple of years. And I'm excited about where the future is for all of us. And that should allow us for, I think, some time for questions.
Thank you, Dr. Turner, for that wonderful, wonderful presentation on competency-based medical education. Truly appreciate it. Let's see if there are any questions and comments for you.
Hi, David. Thanks for doing this. We're actually part of the crosswalk study, so we have been, at least imperfectly, implementing EPAs in our evaluations for the past 3 years. So I know at least some of our faculty are familiar with them. I think one of the challenges is figuring out, how to best incorporate them. Right now, we have all faculty assessing all EPAs potentially, and some are just not as applicable to certain settings. So, and there's a few that I think we've always are left scratching our head about how do we measure this, some of the ones like EPA 14 that are more related to quality and bigger picture things. So I don't know if you have any insight on how people have successfully narrowed down and apportioned between different settings.
Yep, that's a great question. So just in the second question first, around some of the EPAs being more challenging than others, that's one of the lenses that we're using as we think about the EPA revisions, is sort of not only are these the activities that define the practice, but how might one assess them and what might that look like, right? So that's something that we definitely are thinking about. In terms of the issue of who's assessing which EPAs, one of the exercises that as a program that can be really valuable is sort of sitting down to decide, okay, in a given clinical area, what are the main activities that are going to apply to that area? And some of that is pretty straightforward, right? So if you think about the newborn nursery, right, in the newborn nursery, Care for the Well Newborn is going to be their main EPA. And there are probably a couple of others that apply, right? They do like handovers to some degree, depending on the context. And then there are a couple of others. So as a given faculty member, right, if I work exclusively in the newborn nursery, I'm probably only going to have to be familiar with a handful of EPAs. Some of the other clinical areas, it is more broad in terms of the number of EPAs that they would need to be exposed to, like the emergency room or the hospitalists. But even those, you can tailor them down so that in a given rotation, you're getting different inputs from different faculty about the activity, so it doesn't feel like every faculty needs to be familiar with every activity. So I think mapping to rotations and then using that as an opportunity to share with faculty, these are the ones you should be familiar with and be primarily responsible for assessing. And then at the level of the competency committee, you can sort of put all those pieces together so that you have a comprehensive picture by the end. And that has been an approach that has seemed to have worked with some programs that have used, like they've really jumped in and are using EPAs for frontline assessment, is that streamlining and mapping based on clinical setting in which the residents are working.
Hi.
Thank you.
Hi, David.
Dina, go ahead.
Thank you. Hi, David. This is Dina Tom. I am the new program director taking over for Dr. Arandas, who has eloquently done it for 11 years. So I'm learning how to do this job. But I have a question for you that came up at APPD that I think there's a concern from program directors about potential concern that EPAs are intrustable, the word intrustable, and that the implication of that is basically saying that I trust you or don't trust you based on the way that we say that they're competent to do something. And trust is something that people take very seriously. And so it's an interesting idea, and one I think that probably needs to be at least delineated for our trainees, is to say to explain what that means, basically, because trust is something that can be subjective. Obviously, these are objective measures or we try to make them as objective as possible. But is that something that has come up for you, or that you have seen? There was, in one of the sessions, that was something that was like, wow, that is that's not something I considered, but I can understand how it can be perceived if it's an entrustable activity. The word trust carries a lot of weight for people.
It does. It's a good question, and it is it's a shift in mindset in thinking about how we are assessing. And I think you're right. The concept of trust in general, right, comes with a lot of issues. And I think we would be fooling ourselves to say that this is an entirely objective approach to assessment, but any assessment that involves a human has some subjectivity to it, right? And so that, I think, is a part of every assessment that is happening, and figuring out how to mitigate the biases that exist and really make sure that people are focusing on readiness to do the activities. And some of it, relates to the language that we use, right? And so I think you're right. When you call it trust, like, that comes with it some perspectives that some might include. But I think clarifying, what we mean when we say that. And the truth of the matter is, whether it's stated out loud or not, faculty are making those decisions already, right? Because when, you see a patient in clinic and you let the resident go in first, do the exam, take the history, and then come back and report back. Like, there's a level of trust involved in doing that. And so I think trust is a part of what we do. But, there's a difference, I think, between that concept and then putting a label on it in the way that it's labeled with the EPAs. So I think there is some both trainee and faculty development and discussion around that is important, so that everybody understands what it is we mean when we say the terms, and what we're trying to accomplish, which is ultimately, right, development and readiness for practice without a supervisor being present. And there is trust built into that, but it might not necessarily have the same implications that sometimes people have when they use those words. But you are correct. It's something that I think just needs to be clarified with everyone involved in the process as you think about what the assessment looks like. And another way to think about that, or to address it, is in how we ask the questions, right? So if you're using EPA language in frontline assessment forms, right, using a supervision scale and how much supervision is required, is for most, right, a more concrete way to answer the question, and is different from, do you trust this person to do this activity, right? It's how much supervision did they need, and then that should come with, why did they need that level of supervision, yes or no? And then, like, the supervision issue is a whole separate conversation, because there are some people who are over supervisors and under supervisors, sort of, to summarize it. But thinking about what the individual needs, as opposed to what I felt like I need to do based on my frame, is another, like, subtle difference in thinking about this. But one of the ways to mitigate that issue, and really both of them, is volume, right? The more assessments that you have that are lower stakes, that are growth oriented, and are conducted, like, at the bedside, the more of those data points you have, the more you can filter out some of the outliers, right? People who fall on the extremes one way or the other as it relates to assessment.
Yeah, that's a great point. Thank you so much for addressing that.
Yep. So Alice's question from the chat about context is an important one, right? And so I think you are highlighting a really important issue of when someone is in a given clinical area. Like, I'll use my area as an example, right? I'm a pediatric ICU doctor. When residents come through the pediatric ICU, we often spend a lot of time trying to teach them how to become mini intensivists, right? We talk about the ventilator, and we talk about life support in all of its forms and all of these things. But at the end of the day, what most residents need to be learning as a part of their critical care rotation are can you recognize sick, not sick? How do you identify and triage? And those are represented in the EPAs, right? And so thinking about the frame for the given learner that you're working with, and making sure that the educational outcomes for a given rotation match what that person should be doing, right? Because for most general pediatricians coming through our critical care areas, what they need to be learning is not our subspecialty necessarily, right? It's how our subspecialty care relates to being a general pediatrician. And that's a piece that's missing in many residency programs, because a lot of places that residents spend time does not necessarily align with what they likely will be doing for the future as a general pediatrician. And making those things connect differently is a shift in the educational paradigm that is going to be important, right? And after I got into this work at the board, as I was going back and forth to my clinical experience at Duke for the first couple of years, I realized that there were lots of opportunity for us to think differently about how we both are educating and assessing our residents that were coming through to prioritize based on the needs of the general pediatrician, right? And so I think that's a shift in mindset, particularly among the subspecialists that are involved in assessment, so that we make sure that we're all thinking about the same questions and the same outcomes in terms of preparing people to be ready. But that's a really important point as you think about what they're doing and what the expectations are, because no one would expect a general pediatrics resident to be an unsupervised management of a patient on a ventilator, for example. But that's not an activity that a general pediatrician should be able to do. If you're a fellowship program director and you have an ICU fellow, that's a different story, right? And there are a different set of activities for that. But that's a really key point as you think about who's assessing and what they are assessing and how that relates to the output that you're looking for, right? Which in this case are the activities of the general pediatrician, at least in the example I just provided.
Thank you, David. See if there is any other question, comments for Dr. Turner. Dr. Gong, yeah, go ahead, ask question.
Thank you. I'm an neonatologist, and I have been pondering this for a long time. I think that pediatricians should at least know about the complicated cases that happen in a critical care setting and how to manage those patients when they get them after their critical care stay. And as things get more and more complicated, it makes it harder for them to get that experience and to understand, how to manage, let's say, babies with BPD, babies on G tubes, babies that are all these things that are happening. And I don't find that they are ready. And the clinical settings that they find themselves in don't even give them enough time to take care of these complicated cases, which are becoming more and more in our society. So how do we change our mindset that when they come to our rotations of, making sure they can manage a ventilator, that they can intubate and resuscitate, to understanding the complexities of these diseases and what it means in the long run? It just is very disheartening to see how pediatricians are managing these patients on an outpatient basis because of that lack of knowledge. Thank you.
Yep, that's an important question and concern, and I think it relates to in a very concrete way your question of how do we start. I think one place to start is to take the activities that a given group, right, in this case neonatologists, right, feel are the key elements that a general pediatrician needs to know, and make sure those are built into the curriculum in a meaningful way. And so that, instead of, during your NICU rotation, oftentimes there's like an educational curriculum that comes with it, right? And people are getting lectures about the ventilator and how the ventilator works, and about ECMO and extracorporeal support for, severe pulmonary hypertension and all of those things, which are important components of understanding the context of what it means to be a pediatrician. But to your point, what they really need to be learning about, right, is like, what does it look like when a patient has BPD, and they're in the outpatient setting? And so there are, at least a broad level, activities in the framework that address those, and those can be built out into curriculum that are designed to achieve exactly those goals. But you're right, it definitely involves a frame shift at the level of the faculty and the program to make sure that we're prioritizing the activities that are most important for the general pediatrician, as opposed to the activities that are most important for some of us as subspecialists, right? And so I think the subspecialty intersection between the resident, the program, and the subspecialists is an important one to consider as we think about, what the future looks like. Yeah, EPA 6 does cover some of this. Yes, I totally agree, because the world is becoming increasingly complex, and that is an increasing role of general pediatricians, particularly as other providers are sometimes more involved in some of the more routine elements of care.
Any other questions, comments for Dr. Turner? I don't see any, and it's almost 8:30, so many of us need to run to the clinics. Thank you very much, Dr. Turner, for that fascinating presentation on competency-based medical education. Thank you all for attending this morning's Grand Round. I'm going to conclude, and thank you all for attending, and have a wonderful Friday and a wonderful weekend. Thanks you again, Dr. Turner.
Thanks again for having me. I really appreciate it. I'll put my email in the chat if anybody ever wants to talk more about any of the topics that came up. I'm always happy to chat. Thanks again, and I hope everybody has a nice weekend.
Okay. Thank you.